Now, shifting gears, we're turning our attention to an issue that affects nearly every healthcare professional and patient, yet often goes unnoticed: the hidden burden behind the scenes. Our upcoming session, The Hidden Costs of Medical Paperwork: How to Fix the Billing Nightmare, will explore the challenges posed by outdated administrative systems. From time consuming forms to inefficient billing processes, our panelists will explore how these hurdles impact providers, patients, and the system as a whole. To guide us through this conversation, we have an exceptional lineup of experts. Please join me in welcoming Anurayan Joshi, CEO of Increment Healthcare; Karen Lyons, Executive Vice President of Brilliant Health Solutions; Dr. Rishi Mega, Surgical Development of Cloud Services Limited; and Abashki Kumar, Director of IT Solutions. If I can have that whole panel come head on up. Give them a big round of applause. Yeah, perfect, great.
Good afternoon, everyone. I know it's third day and we're all burned out, tired out now, and here we are talking about billing nightmares. Okay, but let me assure you this: we'll try to make it as interesting as possible. Okay, I can't guarantee that, but we will try our level best here to make it as fun as possible. Okay. With that being said, we can probably go ahead and get started. My name is Abhishek Kumar. I'm the director of IT solutions at Iconma. I bring over 2 decades of experience working into healthcare industry, where I have been into the forefront of driving complex digital transformation in the field of predictive analytics solutions on prioritizing high-risk patients, care management, care coordination, and streamlining the whole shift to value-based care transformation. I'm a Forbes Technology Council member and a winner of Healthcare Excellence Award and Global AI Adoption Advocate of the Year Award last year. So I'm looking forward for this interesting discussion today. I will like to call upon my fellow panel members to introduce themselves and share their areas of expertise, and then we can get going right into the discussion. Karen?
Can you hear me? Okay. All right. So I'm Karen Lyons. I work for two companies, Tactical Rehabilitation. I'm the Chief Financial Officer and Chief Legal Officer. And then we have Brilliant Health Solutions, which is a new company that opened in November, which is a manufacturer of orthotic devices. I have an MBA and an executive juris doctorate. We do our own billing, and I know that's what we're going to talk about here. And so I'm so happy to be here and hope I can learn a lot from all of you.
Thank you, Karen. AJ?
Hello.
Yes, we can hear you.
Uh, uh, Good afternoon, everyone. So, uh, third day today. I think everybody is either going to go and then have some party tonight, or maybe go home. I definitely would like to go home. So, starting with me, my name is Anuranjan Joshi. So, like it was difficult to pronounce, so you guys can call me AJ. I think that is better. And I represent a company which is, I think, like the topic clearly says that, right? Billing nightmare. So I own a billing company. We work with uh, all the specialities in hospitals, clinics, and obviously, so I proudly says myself that I like to collect every single cent for the providers what we work for, and obviously solve their challenges in terms of whatever billing challenges actually they oversee while performing the patient care. I My delivery center is in India, and then we have a great team actually. who believes to obviously collect as much possible as fast as they can for all the providers actually across the United States. Yeah, I think I'm pretty much excited actually to share whatever my overall experience says in terms of the billing uh, problems, like right now also happening after bringing a lot of AI in and technology in place. And that is what we're going to speak, I think, next few minutes.
Thank you so much, AJ. So I'll again, as I promised, okay, so we'll start with a fun fact. Okay, so if you walk into any business and it says that I spend 25 to 30 cents of my every dollar just to figure out how I will get paid, you'll be laughed out in the boardroom. In healthcare, we call that as revenue cycle management. So what we will do is we will try to dig deeper onto some of the core issues which are there, and that's where I would like to call upon my fellow panel members to share their perspectives on how they see that. Okay, so starting with, first of all, understanding or your perspective or your understanding of the problem itself. Okay, how do you see what exactly the topic is all about, or how you describe this medical paperwork and the billing nightmare in your own words. Karen, maybe you like to go with first.
All right. So, as I'm sure all of you are very aware, we have so many systems in place, and those systems don't talk to each other. So, we're dealing with insurance systems. Every insurance has its own way of doing things. They all have different forms. They don't necessarily speak with each other, just like the gentleman earlier was saying. The electronic medical records from different hospitals, you have to have a login to all of them, and you walk in and you're sharing the same information over and over. And a lot of times we feel that way with dealing with the insurances. And then the regulations are different. Each person, each company has their own set of policies and things that need to happen, and it's very convoluted. And I think that's the start of a lot of frustration on the billing team side.
AJ, your perspective.
So I'm just watching because like this is endless topic to be very honest, right? Uh, because right, everybody talk about the patient care, which is definitely the goal, but how will you be able to basically do the best patient care if suppose there is no revenue leakage, right? So I spent approximately 23 years. I worked as a biller. I used to be a payment poster, right? When the paper UBs used to be in front of us, reconciling those Medicare and Medicaid, like small cents, right? When we used to post that into the EHR. So over these years, what I had seen is specifically, right? People talk about denials, uh, and then obviously, so Abhishek, I can use some of the things actually what is in the next question as
Sure,
well, right? Because
absolutely. I
because
mean,
this is how actually the conversation is
no,
going to be built, right?
makes sense. No, so just to sum it up, so medical billing is not just an administrative drag. Okay,
Exactly.
it is a financial and emotional toll. Okay, so if you understand the nightmare stems through prior, I mean, your prior authorizations, endless loop of broken prior authorizations, uh, error in the claim coding errors and things like that, and then the payer provider friction. So the clinicians are being burnt out because of they are forced to be data entry clerks, and patients, as we patient, are caught in the crossfire of these confusing bills, and this endless claim denials. So we are basically throwing human bodies at a data and interoperability problem. I think in the previous session we were talking something on the interoperability. Sorry, so that's the core of things. Okay, so with that being said, I like to move on to the next question, which is the root cause. Okay, so let me put it in this way, and it is open to first to our fellow panel members and for others to think also. Like we have in US one of the most modern technology for healthcare. However, we are using billing systems that are built in 1990s. Now, I want to understand from your perspective, what's the potential root cause or cause for that? Is it like the policy problem? Is it the technology? Is it the payer provider trust issue? What exactly is the problem? What exactly is the bottom line?
So that is exactly. So I'm sure in the year of 2000, right? So I'll just break down some of the numbers, which is obviously industry standard numbers. In the year of 2000, the denial rate used to be approximately 8% to 9% on an average, and the reason for most of the denials used to be the billing errors, right? The manual errors, because that particular time a lot of technology was not there, and then it was manually driven process actually. Uh, like we shifted like little ahead in 2010 approximately the denial percentage. Obviously, the new technology came in that 10 years, a decade time, but surprisingly, the denial percentage moved from 8 to 9% to 10 to 11%, right? Uh, Everybody started thinking like 10 years, definitely some of the innovation might have happened, right? The denial ideally should go down, but denial went up. Now, the reason for like upward shift was uh, manual errors went little down, but some specific policy things like started coming in picture, and then those converted into the denials. Uh, Moving back to 2020 or something like that, which is approximately 5 6 years ago, 5 6 years ago, denial further expanded to 11 to 12%, right? And these are the real numbers actually, which is I think I'm sure everybody is facing. Again, like better technology, less manual intervention, but again denials are going up. And whenever I'm talking about like all these percentage are going little higher in terms of the numbers when the overall billing in the United States actually also going high, right? So if you multiply the same percentage with the overall billing happening in the entire health sector, the revenue leakage is basically again going high. Now, in the year of 2025 26, now like when we are talking about right now, the and like everybody talks about AI, everybody talks about automation, the denial further went up, and then it is basically sitting at 13 to 14%. Some of the specialties even basically scaling at 17% of denial rate. So if suppose we start thinking on why these denials are happening, so like in my view, it is provider side. Obviously, AI is coming. First of all, actually, AI is just a term, right? To be very honest. But in the payer side, AI is coming there as well. If payer starts paying every penny, whatever we bill to them, uh, the payer is going to basically definitely lose the business at the end. So, and like I was just talking to my panelist, if suppose we compare the overall revenue for the provider side versus the overall revenue for the payer side, obviously in United States, everybody has to take insurance and then pay the premiums to the insurance company. So, but everybody doesn't go to the hospital, right? So, uh, this side versus this side, obviously, payer has higher revenue percentage, which they can invest into their AI technology tool to reduce the outcome actually at the payer side, and they create a lot of policies, which is again try to basically tackle the policies what provider side are helping right now. So the entire system right now what we are in, and that is what basically I feel very proud that okay, and that is what I said earlier as well, I feel very good to collect each cent for the providers what we work for, because you have to fight for each single claim actually bill it to them. Abhishek was talking about prior authorization. There are a lot of automated tools available right now to automate the authorization, but still prior authorization is one of the biggest denial actually in the industry,
Yep.
right? So, uh, like, do we really basically? And then definitely you need people who understand prior authorization. Providers should understand prior authorization. So this is basically a complete ecosystem, right? And then if suppose again we multiply these small cents to a value, this is what we are losing actually in this paper, or I would not say that paper, but in the entire revenue cycle stream. And before basically I just sum it up here, uh, 25 to 30% approximate providers in United States are still small practices, one doctor, two doctor, or maximum five doctor practices. Now the shift is happening. So obviously, like if you are a provider, you have completed your education and you want to serve to the patients, right? As a business person, as an entrepreneur, or as a provider, right? If these small revenue leakage are not getting filled, to be very honest, these small providers are converting into the bigger health centers, and then health centers are acquiring all these small providers, and they're bringing actually into their specific overall ecosystem. So end of the day, you are getting into that ecosystem where you are no more single owner for your practice. You still will have to basically go and then work according to uh, multiple layers, because those health centers dictate those things. So are we really achieving something actually? And then these small revenue leakage actually what we happen to see in this entire revenue cycle optimization stream, it becomes very important. And then we should see every single specific issue to fix that, and then give that specific edge to the small providers or a mid-sized providers, so they still feel great that they are serving for the patient, and they are still basically having the decision maker for their own practice. Yeah. So
Yep. Karen, your perspective.
Sure. And I would say we are a DME provider. We provide solely to the military, so we deal with TRICARE all the time, East and West. Um, Obviously, government program, and you run into a lot of issues just there or trying to talk to someone. But as we said earlier, there are multiple things causing the problem. But as I sit here and I think of how we got to where we are, our billing accuracy is 99%. We brought billing in-house. We scrub everything from the time the authorization comes in. We have a team on the operations side that scrubs the auth, makes sure everything's there, everything that's needed from the patient is there. And then the order is filled at one of our 12 locations. We have 12 brick and mortar, but we serve another 2,200 some locations around the country where bases are located. Then that's scrubbed again before it goes to the billing. So we bill about $22 million with two billers at a 96% accuracy. And as I sit here and think about, if you're small, if you're a small practice or a small hospital, we all know we don't get 100% of our billing dollars. But if someone's not actually paying attention to that 12% that's missing, because everybody's like, oh, we can't afford to hire somebody. Yeah, you can. If you can hire 2 or 3 people that can scrub everything and increase your billing accuracy by 1 to 5%, you've put a big chunk of money back in your practice that you maybe didn't even realize you were missing. So I would encourage anyone here that, you're not getting all the money on the table. And I know today's theme is, AI and getting rid of people, because people are expensive, your employees are expensive. But you can afford those people if you increase your billing accuracy.
A great perspective. And so just to sum it up, what I could understand, and it's all about misaligned incentives and the lack of trust. Okay, we as payer builds walls, which we call as prior auth, okay, to control utilization. And as providers, they hire the army of billers, medical billers, to scale those walls. Okay, so it's an arms race of medical paperwork. Okay, that's what we get into at the last. Okay, and that's where we are where we are. Okay, with that being said, great perspective. But I do want to share those numbers. What AJ was talking about. Okay, McKinsey estimates that number is rise right now at a staggering 15%, accounts for 15% of the total healthcare spend in which is happening because of the inefficiencies in revenue cycle. That translates to 400, I said $400 billion of things which are getting lost because of in claims processing, in bad debt and billing right now in the United States. So that's the number. That's some real numbers coming from some leading analyst firms like McKinsey's and Associates.
and
With
and,
that,
and that was that was the cash actually should have come into your account, to be very honest.
exactly. So furthermore, they say that streamlining these workflows or automating these workflows could save or could give a net saving to the industry of at least $265 billion. That's what is sitting right on the table. Okay. But with that being said, since everywhere there is AI, and that's what the next question is, that as we are going into all these conferences now and people are talking about Gen AI, agentic AI, AI can do this, AI can do that. Now, to my fellow panel members, I would like to put that question that how much do you think from your perspective in your setup, how you're looking at that AI is really moving the needle in your back office? And how much of do you think it is just an expensive hype? Maybe starting from you, Karen.
So we we have encountered AI through TRICARE. TRICARE is starting to use more AI for scrubbing auth, scrubbing billing claims, those things. And I think when we said one of the issues that causes the billing dilemma is the inability of the systems to talk to each other, or the inability of the people behind the scenes to interpret a HCPC code in the same manner. So if AI is involved from that perspective, we should see at least a standardization of what you're paid by HCPC code if AI is used similarly across the billing groups or the claims payers. I do think it will bring some assistance in there, but from my perspective, I would hate to give up the person on the back end, because that person can contact the patient, they can have a discussion, they can send the patient back to the provider if more clarification is needed to ensure that the claim is billed. Where I think if we put too much AI in that front end process, and with looking at patient care as the number one priority, we're going to miss those opportunities to clean things up and get the claim through.
Great perspective. AJ, can you add on to that?
So
Hype versus reality.
yeah, hype versus reality. Uh, in my perspective, AI is half hype and half reality, what I see right now. So again, I'll take the example of the denials, because there the money is stuck actually, other than like some other issues as well, right? So AI is definitely helping in terms of predicting like the behavior of the denial, which is like claimed by many companies. Even we are also working on that specific aspect. I'm not going to basically debate on the accuracy of that right now, because that is still basically developing into the like overall domain. Uh, the front end denials are obviously like getting help with AI, but when we shift our focus actually from the provider side denials versus the payer side denials, now in the payer side denials actually we see the real challenge where the AI still will have to basically work a lot, uh, because again, I said some time back, right, it is AI versus AI, right? So their model is to create a firewall and block like the every uh, clean claim, what we call it as, right, passing from this side through the clearing houses and then reaching to the payer. And obviously like uh, payer policies will have to be aligned with the AI, and that is what something actually AI is still figuring it out how this can scale up in future. Uh, is it going to basically remove or like eliminate all the denials and then increase the cash flow? My take is going to be no. Uh, if the question is yes or no, right? How much it can, obviously we can always debate on, like, 99%. Like, Karen is lucky actually, because her overall numbers are looking great, because obviously she might have done something with multiple tools, not limited to one specific tool, right? So again, the problem here is that, if suppose we segregate the bigger health centers, an army is there to identify and understand that, okay, what specific tools or channels they should bring it into that specific health center to prevent the cash flow. Uh, but the smaller and the mid size, they still will have to understand that, okay, what exactly is the automation going to help them. And then there you need definitely some automation channels as well, and obviously you need this mind as well, because end of the day, if suppose AI start treating the patients, then we don't need providers. It's very simple, right? So if and this is what something nobody would like to, because there is an empathy, there is a personal connect. And the same thing actually goes into the billing as well, where you definitely need expertise, you definitely need some, like, physical minds actually who can work on the AI, because AI was developed by a human, and then AI has to be managed by human itself.
No, interesting perspective. And again, just to piggyback on that one, that we there is a consistent fear in the market that AI is been replacing jobs, definitely with the massive layoffs which are happening. And day before yesterday, I had the panel discussion on the human-centered approach for the AI. So if you see that AI, I'll just take one quick deviation on that one, that AI is not simply replacing any job, okay? It is replacing those jobs which were not supposed to be done by humans anyways, okay? It is replacing those jobs which are repetitive in nature. So it is, but when it comes to the the thing which human has to do, so we have to get back to doing what humans should do, okay? Solving the complex problems, solving with empathy, critical thinking and things like that, okay? So that's what we should have done right from the get go. But again, we will go on to that topic, and that can go into a whole different rabbit hole. But coming back to the hype versus reality, what I will sum it up with, that definitely, as he's saying, 50-50%, as AJ you just mentioned, that AI is definitely doing great in certain areas on the front end, which is, let's say, ambient listening for unstructured clinical notes, okay, and transcribing it for me, summarizing it for me, automated medical coding, okay, it's via natural language processing, NLP. It is doing that. In terms of predictive denial management, it is doing some phenomenal job in flagging those claims by matching with all the criterias where, which could be likely to bounce before they are sent to the payers. So it is definitely doing some great work in those areas. However, when a vendor comes and says that AI will magically fix your broken workflow, AI will magically fix your garbage data, unstructured data overnight, that is an expensive hype. That is a hype which we should avoid, and we should, take care of that, because anything on a broken workflow or anything on an unstructured bad data that you're putting, the outcome is the same. It can have a fancy terminology for that one, but you will still have the same outcome, and that leads to failure, okay? So thanks a lot for the insights onto that one. I'll move on to now the third and the most important topic on this one. Is we are talking so much about the provider's bottom line over here, but what about the patient experience? Okay, what about the person, okay, who is, holding that confusing explanation of benefits? So what we are doing to solve that billing nightmare for the person who is actually on the hospital bed? So again, this time I would like to go and with AJ first, and then Karen can add the insight.
So, patient care, like, that's the eventual goal for every individual actually who's into the healthcare industry, right? Uh, I'll give you a simple example, right? I think the same thing we were talking as well, right? A patient has two insurances, primary and secondary. Uh, for whatever reason, actually, primary didn't pay, and then secondary maybe paid or maybe partially paid or maybe like didn't pay, right? And suddenly actually a hefty bill is coming at the patient, and patient definitely is not going to be happy to see that bill. And this is definitely a very classic example, and this is not as this is very usual process actually. Most of the providers they see, and this comes into those 10-15% whatever numbers we spoke earlier as well. Now is patient going to be happy after seeing he had two insurances? He obviously thought that okay, my primary is going to cover my bills. If primary is not covering, that is the reason I took the secondary. Secondary should take care, but the secondary is also not taking care of that, and then suddenly I am getting a $10,000 bill. How would I pay that? And eventually what is happening, right? He is not in the position to pay that bill. He's upset. He's upset to the provider actually who had provided the services, because end of the day provider didn't get paid eventually from the insurance company, and that is what the denial was, right? And then provider also needed to get reimbursement done because uh, he or she had provided the services, right? Now in this entire, and this is nightmare, this is what basically the nightmare is all about. What provider is gonna face here is an upset patient. Uh, the patient is definitely not gonna come back again if suppose the problem is not solved. So the lost revenue uh, in the next visit. And then how do we solve this problem, right? So that is one of the reason actually. And then their AI and the human intervention basically are helping right now, where obviously everybody understand coordination of benefit and then initial eligibility verifications and all these processes, right? uh, what we believe, if suppose there is no eligibility, the claim should not go out. So it has to be set, the system has to be set across in such a way where uh, all the workflows like what Abhishek was talking about should be set in such a way that the end goal, the every patient statement which is going out of the system actually and reaching to the patient's address or email should be verified at least multiple times, maybe with the help of AI, maybe with the help of human, but it should not just basically blindly go because of inefficiencies coming from the primary insurance or a secondary insurance, or maybe an AI mistake or maybe a human mistake, right? Because end of the day, and this is the real example, and I definitely would like to basically keep it such a way that you understand with what you all are facing and what we are trying to basically solve at our end.
Makes sense, that how you can remove those jargons, okay, and having some consumer friendly billing interfaces, or doing some upfront cost estimation. So as a patient, I am not now getting a bill 45 days post discharge because of some network gaps or because of something on the secondary insurance where I was on the hospital bed, and yes, you did sign when you were taking the anesthesiology, and the anesthetist gives you this one which was out of network, so you have to pay for that anesthetic. Okay, that's amazing. Okay, and that happens. Okay, so this has happened. It is not really a surprise. But again, Karen, would love to hear your perspective on this.
So, as I mentioned, we only work with TRICARE, so we cannot provide a um, a medical device without a prior authorization. So nothing leaves our office unless we have the authorization. Now, we have run into, because it's the government and they can do what they want to, what we have run into before is take a specific product and we have the authorization and we provide the patient the product. And because we deal with active duty, it's 100% paid by TRICARE. However, they decide between the time they did the auth and by the time we get the bill out that they're not going to cover that product anymore. And even though we have worked on trying to get our money, they do not pay for those products. So we're just stuck at that point. And how we fix that, we're not there yet, but we're working on it.
Thanks a lot for that perspective.
So
Sorry, you want to add something? Yeah.
I'll just add one, right? So this, so we are very small panel, right? Only three. I think we were supposed to have five, but two backed out, or maybe they couldn't make it, right? So Karen is a provider. She's the end actually what we are talking about. I am a billing specialist, right? I try solving problem, and Abhishek is a IT expert in AI technology, and that is how actually we are trying to relate and create a situation where, and because this is what it is, right? So we talk 100 things, we talk multiple examples or whatever it is, but end of the month, if suppose your cash flow is has a leakage, it will be difficult to basically run the practice. And I really had seen in my career where, and I work with a lot of autistic providers, right, in autism industry, under behavioral health, and those specific providers, specifically into United States, are a I would say that small scale, like I'm not talking about the big groups or something, because that industry is still basically consolidating right now. A $20,000 to a $50,000 is something actually most of the autistic like providers are making right now. Just imagine your $30,000, $40,000 is stuck. Next month, you will not have basically money to pay your bills. Those BCBAs, those RBTs, you will have to definitely pay the salaries to them. It is definitely going to be nightmare. And then I think the organizers has rightly selected the topic, the nightmare in billing, or whatever it is, because that's what it is all about, right? So I think this is a collective effort. A provider should definitely learn the new technology. How they will learn, it is our responsibility to go and then tell them, this is how the system is building up right now. Because end of the day, I personally uh, do not think that a doctor should learn the technology or a provider should learn the technology just for the survival. They should learn the technology because the technology is evolving right now, but their main focus should be always the patient care, and then obviously that should be fine.
Absolutely, absolutely. So let's now, this is an analogy time. Okay, so how we now, we have heard a lot about medical billing and everything. So imagine you take your family to a restaurant to have steak. Okay, you order steak, it comes, you eat it, but restaurant doesn't give you a bill. Instead, 45 days later you get a letter with some secret codes in it. Okay, now they have spent 3 weeks negotiating with your credit card company to figure out the value of the steak that you ate 45 days before. Okay, and oh boy, the waiter didn't officially document that when you ordered the steak, it was actually, you ordered it medium rare. Okay, which means now the credit card company denies the payment entirely. Okay, now what happens? Now what happens, the restaurant employs three core back office team whose job is just to now call this credit card company, negotiate and prove that you ate the steak. Okay, and you have to prove that you ate the steak, and then keep begging for money. Well, welcome. That's our medical billing system. That's the US medical billing system we are talking about. That it's a massive retroactive negotiation process that punishes everyone who is involved. So I just wanted to give that analogy just to bring with the clarity, that bring with some funny this thing, that this is exactly what we are facing. But now as we move towards the end, again I would like to call upon Karen, if you want to give some final takeaway, then AJ, and then we can just summarize, and then we can be open for any specific questions the audience has. Go ahead.
So I thought he was going to tell the story when we first met, because I didn't know what he did. He didn't know what I did, and I was talking about taking billing private because it saved us a ton of money, and we had more control over taking care of everything up front. And then he surprises me and says, "Well, I do medical billing." So we had our uncomfortable moment there early on, but I do think it goes back to if you are the provider, and I would say especially in small practices, if you're not paying attention to the portion that you're missing in your billing, then you really need to pay attention to that. I mean, if you're $1 million business and you're missing 10%, there's $100,000. And you could have probably hired somebody for 50 and at least you would have netted 50. Or you work with your billing agent to make sure that the information that you're providing them is as accurate as possible, because it's kind of the old garbage in, garbage out. If the information the billing group is provided is not accurate, then you're going to get more denials. So a lot of times I think you would find, if you really look at it, it's worth adding that person, or maybe it's AI in the future, to scrub your claims before you ever submit them, because somebody can spend minutes to hours scrubbing a claim, but if you submit it, it's denied, you're looking at 60 days to get your money if you get it that soon. So I think that's a big point that I would make.
Sure, sure.
Question.
Please go ahead.
I don't know. Yeah, there we go. Great stuff so far. Just curious about a small town single provider. Is there a ratio that you've found? I know you said you had, I think, 12 brick and mortars, but you only deal with military. Is there a ratio that you've found that would um, cover the costs of hiring a biller? Is it like 1 to 5%? If they can improve the billing 1 to 5%, something like that. Any ratios of that might be of interest to smaller town providers?
Maybe
Okay.
I think you can take
So,
this one definitely.
so I definitely, this is a panel. I don't want to basically promote my company, but your question is pretty straight, right? Small town provider, single doc practice, or maybe a couple of doctor practice. Uh, like, see, I am from India, and in US, obviously, like you have multiple laws actually for the minimum wages. If you hire a person, right, you will have to basically pay some specific like dollar value every hour, right? And which is obviously governed by the government, right? Uh, the optimization, what maximum you can do, the single person actually doing multitasking, and then you assign different responsibilities, and that to cover the overall spend on that specific individual, right? And then you shift. Say example, this is the value of X, right? You move into the billing expertise, and you go to a company which basically employ multiple people, multi-specialty clinics. So she works on military, but my company does all the specialties. So I have experience for, so basically, forget me, right? I'm definitely not going to basically promote my company, but the billing company, they have experience on multi-specialty EHRs. They have experience on different specialties, right? It cannot be limited to one specific specialty. They have people experienced into the payments. They have experienced people into the AR collections. They have experienced people for coding, denial, and all the different verticals. So what eventually you are getting, you are signing a billing company, and you are not hiring one person who's doing all the job, but you have an army who's doing basically all the job for you in fractions. Uh, Today you are on one specific EHR, and tomorrow suppose you migrate to another EHR because of whatever different reason. uh, the biller actually you might hire may not have that experience, so obviously training cost comes in place. But the billing company, you will definitely reduce that cost. Billing company, if suppose an employee goes out of the system, they have still basically somebody to take care of your work. But the employee actually at your end, which you can afford maximum one person, if suppose because of whatever reason that person goes away from the system, then you are stuck. And then I was talking some time back, everything is basically a cycle based, right? Medicare pays in 20 days. You miss one cycle, you are anyways down by 20 days, right? So every payer pays, and payer is definitely, they are inclined to hold your money, and you will have. So this is the benefit. And then to answer your question, the actual question what you had, the cost is definitely going to be X minus multiple factors if you go into the billing, uh, like companies.
Thank you so much. Karen, would you like to add anything to that?
I would just say a simple rule would be to, if you're $1 million company and you're losing 10% to denials, and it's going to cost 3% to hire the billing company, you're still ahead 7%. If they raise it to 100%, but you're not going to hit 100%. But if you hire a billing company, they need to give you a percentage that they think there will increase your claims processing, and then you can just do the math to make sure that works for you. Now, whether that's through, and that's what happened to us. We had a third party billing company, had worked with them for years, and we started looking as our company grew, the percentage we were being charged was so much more than we could actually hire and train the people to do. We estimated 500,000 the first year. We hit over that in savings, and our accuracy increased, but we put the processes in place to make certain that what was coming in was accurate before it hit billing, and we lost a lot of that as we grew with the billing company. So we still feel we're probably saving 1.5 million or so a year by doing doing billing ourselves and having control over, if you send it to the billing company, at least the way the one we worked with worked, we did the work, sent it to them, they hit the send. And now if it comes through our billing department who knows our business, they're scrubbing it one more time before they hit send. So there again, if you hit send and you get paid first time through, your cash flow is increased tremendously. So again, I think you can do simple math with that, and you'll find a point where one works better than the other for you, maybe as a smaller business. But as we got up into the $20 million and up, we're definitely doing well. And we've thought about offering billing services, but that's not what we do. Our core business is taking care of those who serve.
Makes sense. So basically, I think if I sum up what we are saying is choose the right tech complemented by the right people partner or partner company to help you with that one. I think that will safeguard you, the risk mitigation of all the things that AJ mentioned about people leaving or, you saw getting into the new EHR and those kind of things. So you are literally saving all those efforts. But you still need to make sure that you have the proper tech and proper monitoring or overseeing to manage the team that you are getting in.
and 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 nobody wants to be ever considered as a small provider, right? Because that's the aspiration, right? You start small but you aspire to become bigger, right? And when you aspire to become bigger, then obviously you have to have a right channels, uh, in terms of, because see, again, sometime back I said, right, as a provider your focus should be always to treat and give the best patient care, rather thinking about like all these operational things. And like by 4 o'clock you were thinking that, okay, if I don't submit my claims today, then I'm going to have a cash flow issue, right? So but at that particular time, if you don't have this problem in your mind, then 4 o'clock you can see another patient and you can increase obviously your footfall, right?
So we have one more question. Please go ahead.
Hello, everyone. My name is Cynthia, and I'm the CEO of Beauty Tech, Beauty from Within Technologies. We actually have two proprietary engines, Rita AI and Prism AR, that will help with the billing. I have 15 years in reimbursement, so I know the challenges. When I worked in corporate America, the legacy systems, they lacked efficiency and integrity. And being that I'm a clinical social worker, I know how to build it so that it can actually combat that. So the question I had was for behavioral health. I know that you said your billing company dealt with a lot of like specialty. What have you seen? Is it more of a higher denial rate for behavioral health because they use licensor, modifiers, place of service, so how do you deal with that?
Okay, so in behavioral health, obviously denial percentage is scaling approximately right now 7 to 8% specifically into the behavioral health sector. Behavioral is an umbrella, right? Under behavioral, right, your mental comes, speech comes, right, autism comes, and multiple things comes automatically. uh, the best part actually is right now in behavioral health, the payer reimbursement is good if you compare with the other specialties. uh, but again, the same type of denials, right? You get stuck with authorization if you don't have. You get stuck with your place of service denials because obviously you have multiple place of service like home care and then clinic and school as well in autism, right? So again, the answer is very much simple, right? So uh, we have expertise broken into different type of domain requirement, right? So people who work on denial, they keep continue working only on denials, right? So they don't basically think on how the claim is going to be billed because claim billing is done by somebody else or some other team, right? So since what we have done or maybe what any billing company have done actually, so they have segregated the responsibility into different channels. So the person who's doing their job, they are like good at their job. So if suppose in the front end we try keeping clean claim ratio at 99%, like Karen said, obviously your denial percentage are going to go down, right? So everybody does their respective job based on their experience, and then uh, try to eliminate those small problems, right? Like missing one modifier, which may
Yeah,
increase
and
the
it'll be
denial,
upper.
right? Right.
Yeah,
So again, like everything is, so billing is a time bomb, to be very honest, right?
very true, very true. But yeah,
Right.
thank you so much, and I will follow you guys on LinkedIn. Okay.
Absolutely, absolutely. So I think we are all on time. So again, fixing the billing nightmare is not just about protecting hospital margins. It's about protecting the quality of care. If an hour spent by my doctor or by my nurse into arguing with the payer portal, that's an hour stolen from me as a patient. So it's high time that we start putting technology at work, for the betterment of the patient care rather than the other way around. So again, with that being said, thank you all for being here, and it was a great discussion. Thank you so much, Karen. Thank you so much, AJ, for all your perspectives.